Good afternoon, everyone. Hello, and thank you for joining us. My name is Ruthie Marker. I'm the Education Program Manager of the Allergy and Asthma Network, and I'm thrilled to welcome you to today's webinar. We have an exciting session, and I'm delighted to introduce today's presenter, Dr. A Lieberman. With his extensive knowledge and experience in allergy and immunology, we're in for a really enlightening and instructive session. So before we start today's program, we have a few housekeeping items to go over. First, all participants will remain on mute during the webinar. We will record today's session and upload it to our website within a few days. You can find all of our recorded webinars at allergyasthmanetwork.org. You can scroll to the bottom of that page to access this recorded webinar and any upcoming events. Our webinar will run for 1 hour, included a dedicated time for question and answer session. We will address questions at the end. However, you are welcome to submit those at any time using the Q&A box located at the bottom of your screen. A team member will be actively monitoring the chat. If you have any questions or need any assistance, you may do so at that time. We strive to answer as many questions as possible before concluding today's session. This Advances webinar is sponsored in partnership with the American College of Allergy, Asthma and Immunology. ACAAI offers CMEs for physicians and attendance credits for all others. You can create a free ACAAI account and obtain CME or attendance credits through their member portal for these Advances webinars. All attendees will receive a certificate of attendance. No other continuing education is provided. A few days after the webinar, you will receive an email and supplemental educational information and a link to download the certificate of attendance. We will also be adding the link for the certificate of attendance in the chat, so keep an eye out for that. So with that, we'll go ahead and get started with today's presentation. The title of our webinar today is Eosinophilic Esophagitis, Understanding and Managing the Condition. Eosinophilic esophagitis is an increasingly recognized immune-mediated condition that poses diagnostic and therapeutic challenges for clinicians. According to the American College of Allergy, Asthma and Immunology, EOE affects about 1 in 2,000 people. So let's go ahead and get ready for a great presentation as we delve into the latest advancement in understanding, diagnostic, and managing of EOE. It is my pleasure to introduce today's speaker, Dr. A Lieberman. Dr. Lieberman was born in Memphis, Tennessee, and graduated from the University of Texas in Austin before returning home for medical school at the University of Texas Health Science Center. He completed his residency in internal medicine at Washington University in St. Louis, Missouri, followed by a fellowship in allergy and immunology at Mount Sinai Hospital in New York City. Upon completion of his fellowship, he returned home to work at the University of Texas and LeBonheur Children's Hospital. He is the past chair of the Food Allergy Committee for the American College of Allergy, Asthma and Immunology, and is the current co-chair of the Joint Task Force on Practice Parameters. Also, he is an associate editor for the Annals of Allergy, Asthma and Immunology, and is a board member and current chair of the American Board of Allergy and Immunology. He lives in Memphis, Tennessee with his wife and 2 daughters. Thank you again for being here today, Dr. Lieberman. I will turn it over to you.
Oh, thank you very much, Ruthie. Very kind introduction. I want to thank both Allergy and Asthma Network as well as the American College of Allergy, Asthma and Immunology for putting this on and inviting me to go over the topic today of eosinophilic esophagitis. I want to make this as clinically relevant as possible, so we are not going to get too much into any kind of basic science or pathophysiology. I'm going to keep this as clinically relevant for a practicing clinician, obviously highlighted for allergists, but also I'm going to keep it relevant if there are any other nurses involved or any patients or parents of patients with EOE. Hopefully there'll be really good practical take-home points from this talk. Okay. All right, these are my disclosures. Actually, none of these are relevant for today's talk and shouldn't be any conflicts with what we're going to go over today. The only conflict I will go over, as Ruthie pointed out, I'm the current co-chair of what's called the Joint Task Force for Practice Parameters, which we come up with guidelines for allergy immunology topics such as EOE. And a lot of the data, the guideline recommendations I'm going to present today will be from our Joint Task Force practice parameter. So maybe some conflicts of interest in that as we put it together, but that is not a funded position in any way. Okay. So over the next about 40 minutes, I'm going to go over these objectives, and then we'll leave a good 10 to 15 minutes for questions at the end. So we're going to go over evaluating the role and limitations of food allergy testing in guiding dietary management, as well as in diagnosis of EOE. Compare treatment approaches for EOE, including proton pump inhibitors, topical steroids, dietary therapy, and biologics. And most important, develop a patient-centered approach to treatment using principles of shared decision-making. And that's what you'll notice in the guidelines as we go through them. Okay. In order to frame our discussion, the majority of what I'm going to present to you today is going to come from one of two main resources. And actually throughout the talk, especially in the treatment section, I'm going to show you comparisons of these two resources. The first resource is the Joint Task Force Practice Parameter. So this was a combined guideline that was the allergy societies. So the Joint Task Force is a combined project between the American College of Allergy, Asthma and Immunology, as well as the American Academy of Allergy, Asthma and Immunology. And we come up together with guidelines for allergy and immunology topics, such as EOE. But in this parameter, those two organizations, the Joint Task Force, also teamed up with the American Gastrointestinal Association, the AGA, to combine a joint GI and allergy guideline. And that's what we're going to present now. That, as you'll see, was published in 2020. So with the rapidity of medical knowledge and research nowadays, in some ways, the 2020 parameter is almost not out of date, but has some things that needed updating. And so we will use that resource, and then in more updated one, we'll kind of compare it and add to that guideline using the American College of Gastroenterology, the ACG clinical guideline, which just came out this year. And so we'll show differences in treatment recommendations between these two documents, between these two guideline documents, and kind of show where they're mostly similar, where they're very similar, where they're a little bit different, and talk about why. All right, just one quick slide. Ruthie had kind of gone over the prevalence in the introduction. I'm not going to go too much into this. I always find it hard to kind of figure out, numbers, especially when they talk about number of cases per inhabitant year or something like that, as you'll see here. All I know is when I started on faculty about 14 years ago, we started a joint gastroenterology and allergy EOE clinic through the pediatric hospital. And we started it with once a week seeing patients with EOE. And that quickly ballooned. And now we're once a month. And we're now doing it essentially once a week because the need and the demand became so much that we couldn't just do it once a month. And now we're filling that clinic once a week. And I was just telling Ruthie before this morning, I had our EOE clinic with gastroenterology and myself seeing the patients together and really used a lot of what I'm going to talk about today in the clinic. Okay, so let's start out with the diagnosis of EOE. In the past, you may or may not have realized that the diagnosis of EOE required symptoms of esophageal dysfunction, and we'll talk about what those symptoms might be, in addition to an endoscopy with biopsy showing 15 eosinophils per high-powered field. So of the 40x on the microscope, seeing at least 15 EOs per high-powered field. Now, the current criteria are very similar, but as you may be aware, the main change that's happened in the diagnosis in the past several years is eliminating the idea that you have to be PPI responsive, that you have to have a trial of a proton pump inhibitor before you diagnose a patient. So in the past, they would get a biopsy. Before you could call them EOE, they had to go on at least 4 to 8 weeks of a proton pump inhibitor, and then get another biopsy and show that the inflammation was still there. So the newer kind of thought in diagnosis is we no longer require the PPI treatment before we call someone having EOE. So a patient, gets a biopsy, there's greater than 15 eosinophils, they have some form of symptoms, you can essentially say they have EOE at this point. Now, you do need to make sure there's not another reason for esophageal eosinophilia. That's where it gets a little bit confusing because, for example, gastroesophageal reflux disease, or GERD, in some reports can be the cause of that inflammation. So when you biopsy them and they're not on a PPI and you show the eosinophilia, and then you put them on an acid blocker, and then it goes away, was that reflux or was that EOE? And we'll talk a little bit about how to differentiate that, or why it may or may not matter in the treatment section for PPI. But just realize most consensus criteria nowadays do not require a trial of PPI, meaning if they have eosinophilia, you don't have to give them a PPI to call them EOE, but you can use that PPI as a treatment, and we'll talk about that. Okay, so what are the symptoms that they may present with? So in the pediatric world, typically that's going to differ than the adolescent and adult world. In the pediatrics, when we see kids with that are very young presenting, it's going to be something like food refusal, failure to thrive, or failure to progress to solids. Once they get a little older, it's kind of non-specific symptoms. Abdominal pain, nausea, vomiting, and regurgitation is what we often see, and I'll show you our data. And then as they get older to adolescent or adult age, it's more going to be trouble swallowing, dysphagia, food not going down, or the overt food impaction where the food is stuck. And oftentimes they'll end up in the emergency department needing that food bolus to either be retrieved or pushed through or something else. Now, in our center, we looked at our patients a few years ago, and we showed that this is a pediatric and adolescent center, so we don't have adults in this cohort. But our most common presenting symptom of why that patient came to the doctor was actually abdominal pain in our cohort, followed by vomiting. The food impaction and dysphagia we saw in our adolescent cohort, but it was a little smaller than our total cohort. And then other things such as failure to thrive, or they got a biopsy for something else, made up the rest of the diagnosis. Now, realize this would change if you had a cohort of adults where food impaction and dysphagia would be much more common. But I just put it up there to realize that if you're taking care of kids, you really have to have it on your radar that if you have somebody with just abdominal pain, vomiting, especially in the setting of an atopic kid who has other allergic conditions, that it needs to at least be on the radar. The other thing you need to have on your radar as you're talking to these patients is what they call the impact symptoms. So they use this, this acronym to assess these symptoms, but essentially they're all saying the same thing, meaning patients may not tell you they're having the symptoms, or they may have modified their lifestyle so that they're not having the symptoms anymore because they stopped doing the things that bothered them. So when we're talking to patients, we'll often say like, oh, are there any foods you avoid? And we don't just mean, are you allergic to any foods? Maybe the patient stopped eating steak because the steak kept getting lodged, or it wouldn't go down. So they may not tell you that, and you have to actually ask them these questions. So is this the last person at the table for meals because they're eating so slowly? Is this the person that has to drink a glass of liquid or water every time they take a bite of something that is a hard texture to get it to go down? Do they cut that steak or chicken breast into tiny pieces so that it doesn't bother them when they swallow it? These symptoms obviously are not pathognomonic for EOE. It doesn't mean everyone who's a slow eater has EOE by any means, but it definitely is something you need to think about if you're a provider and you're asking them these questions and you're trying to get how much does this problem really bother the patient? Well, they may not say it bothers them because they've altered their lifestyle, but we don't want them to have to do that. So we want to tease those symptoms out to know if we can improve on them. Okay. Endoscopy is still required for a diagnosis. You have to have endoscopy with biopsies. You may start seeing this thing called the EREFS, E-R-E-F-S, which stands for the findings on endoscopy: edema, rings, exudates, furrows, and stricture. And this is from that ACG guideline where they're showing examples of all of these findings. And so edema is not so easy to visualize on these pictures. It's usually, they say, loss of vascularity, or they can't see the vascularity very well. The other ones are pretty easier to see. Linear furrows are the kind of train track or tram track lines going longitudinally down the esophagus, which are pretty obvious in that top middle picture. It's probably the best example of them. The white exudates, which you can see really well in the top right, they're all over there. Commonly thought to be Candida esophagitis. If the person isn't knowing and they just see it on scope, oftentimes they'll think maybe it looks like Candida esophagitis. And then the rings, which is best visualized in the bottom left picture, you can see there the concentric rings going down. Once again, none of these are pathognomonic for EOE, meaning if you find them, it doesn't mean the patient has EOE. But they're most characteristic. And in our patient population, the linear furrows are the most common thing we see. The ERS score is just a way to objectify and put a number to these findings so that you can see objectively if they change over time with treatment. You go from a higher ERS score to a lower, suggesting that whatever you're doing is helping. But so just so you know these findings and that you're well aware of the ERS score, I'll put this up there, and then you can see what the scoring for each, meaning rings can be scored 1 to 3, and the higher the number, the more severe the disease. So if you see the ERS score coming up, you'll know kind of what that means. So the other way to follow this in time would be, or to diagnose it, would be to use one of these newer diagnostic modalities. Now, no one that I know of is using these for initial diagnosis, probably not their best use, but there are centers starting to use these more and more to follow in time, a way to follow disease without having to undergo a full endoscopy with biopsies, right? Because if you treat these patients, or if you're a patient yourself, you know how annoying it is, or the risk and the cost of going through an EGD or with biopsies every time you need to know if a therapy is working. And so novel, less invasive procedures are being developed. The one that's probably furthest along, at least that I've seen, is the esophageal string test. That's got this little degradable capsule with a little metal ball inside of it. You have the patient swallow it, and there's a string attached to it. And then you have the patient, you tape the string to the outside of the mouth. You let it sit there for 1 hour. They have to drink a little water to get it down. Once you have it in there for 1 hour, you essentially just pull it out. It's interesting, the metal ball will probably stay in there, will get degraded and stay in there. And they say, not to get an MRI within 24 or 48 hours afterwards, because the metal ball is still in there. But after you pull it out, you send it off. It has to go to a special lab, and then they will give you a readout essentially of eosinophilia. So it can detect whether there's continued eosinophilia in the esophagus, but isn't able to obviously tell you much else beyond that. So the way, if you're going to use this, would be to follow a course in time when you've got a patient probably pretty stable overall. If you're changing it a lot, may not be the best, and definitely not useful for the initial diagnosis. On the right is the cytosponge. It's a very similar thing. It's kind of a sponge encased in this degradable capsule where you swallow it, and then the capsule will dissolve, and then the sponge will then be pulled out, very similar to the string test. I just haven't seen it as much clinically as far along as the string test is. There's a nice review of the string test and how to implement it in your clinic if you were a physician and wanted to do this, in that reference down there at the bottom. What we do at our center is the transnasal endoscopy, and you'll see this more and more centers using this. This is a less invasive endoscopy in which the benefits is the patient doesn't have to undergo general anesthesia in order to do a transnasal endoscopy. So many, for example, allergy clinics will use a scope to visualize the nasal passages, looking for things like nasal polyps, and then pass that a little further into the area of the voice box, what you're seeing kind of in picture B there. What the transnasal endoscopy does is it does that. It has a little longer scope that then goes all the way down into the esophagus, where then you can visualize the esophagus and then take biopsies. But the beauty is the patient never has to be asleep for this. And so in the picture on the right, what you're seeing is Dr. Shi. He's the gastroenterologist who works our pediatric EOE clinic with us and does the transnasal endoscopy at our center. And what you can see is a patient there who's wide awake, doesn't have to get any general anesthesia, a pediatric patient who then you can, do this transnasal endoscopy, get biopsies, and save them the general anesthesia. It's also obviously a lot quicker. It theoretically could be done in the clinical setting. Most centers still do it in the hospital setting, but could be done in the clinical setting as well. So just so you're aware, these are procedures that are less invasive or non-invasive, hopefully as a way to follow these patients in time and subject them to less general anesthesia and full EGDs. One final diagnostic thing that's new is the IC severity scoring system. So this was developed through the American Gastrointestinal Association, the AGA, and it is a free app that you can download if you're a clinician. And essentially, you just open up the app, you tell it the patient's age, and then it asks you a series of questions about their most recent endoscopy. What did it look like? Maybe what was the, how bad was the histology? How many eosinophils there were? How often the symptoms having the patients having symptoms? Is it daily? Is it weekly? Is it monthly? And it goes through a few questions like that. And then at the end, it gives you this severity score where 1 to 6 is mild, 7 to 14 is moderate. This theoretically has a couple advantages if you want to use it. One is it tries to objectify the symptoms and the severity across centers. So every center or clinic is using the same thing. And we all could, say, oh, they were a 15 and now they moved to Memphis and I'm seeing them and I do it and they're a 6, so it's better. The other way to do it is theoretically you can follow a patient over time with it. So you do it at baseline and they're very severe, let's say a 16. You give them treatment, they get another endoscopy, you redo their IC score the next time you see them and it's down to a 5, and it just gives you some objective marker that perhaps the overall disease is better. So you can think of it somewhat like what we do in asthma, right, with an ACT score, an ACQ score, a way to follow it somewhat objectively beyond just asking the patient questions. So a nice little thing if you want to use this in clinic is there. It's free. It's easy to use. Okay. So that was the updates in the diagnosis. And now we'll get into the meat of it, which is update in treatments and kind of where we're at with that. Okay, so here are the kind of major changes over the past really 5 years or so that are different than what I was doing when I started the EOE clinic here for sure. Number one, as I talked about, you no longer are required to put the patient on a PPI to A, either prove they have EOE, which we used to have to do, or B, as a first treatment. It's an appropriate treatment, but it no longer has to be the first thing you reach for if that doesn't make sense for that patient. Next thing is shared decision-making. So in the past, the algorithm was, okay, you have eosinophils, you go on a PPI. If you're not responsive, I'm going to either kind of give you diet or swallow topical steroid. And that's the only place we can have shared decision-making. Now you have shared decision-making from the onset of, does PPI make sense? Does swallow topical steroid make sense? Does a biologic make sense? Does a diet make sense? What makes sense for the patient and the family beyond just here's kind of the algorithm? The next thing is food allergy testing is not really helpful and not entirely recommended anymore. And we'll go over those recommendations. Next, dietary therapy. This lots of data has shown that one food avoidance is probably as good as even 4 food avoidance, and we'll show that data to really tailor dietary therapies much better for the patient. And lastly, obviously, we have 2 FDA-approved therapies, which we did not have, for example, at the time of the JTF AGA practice parameters that we put out in 2020. We now have 2 that are approved, and we'll go over those. Okay, so let's start with the proton pump inhibitors. And for each of these, what you're going to see is the guideline that put out the recommendation. So on the top is the AGA-JTF, which was the 2000, and then the ACG, which was just published in 2025, and can see how they are similar or different. And so for PPIs, what you'll see is the AGA, our document said, in patients with symptomatic esophageal eosinophilia, we suggest using proton pump inhibition over no treatment, and noted very low quality of evidence, giving it a conditional recommendation. And the ACG had a very similar statement. We suggest PPIs as a treatment for EOE with a low quality of evidence, and once again, a conditional recommendation. And so what this conditional recommendation means, it's a reasonable therapy. Not everyone would want this, and it's a great place to use shared decision-making, right? Because we have other therapies, and it's not such a strong recommendation that it's like, really, you know, everyone should use this. No, that's not what we're saying anymore. All right, so if we're using PPIs, here's kind of the notes on what we can expect and how to use it. So we still use high dose. What that looks like in children is something like 2 mg per kg per day, and can be daily or twice daily dosing. Typically going to max that out at 40 a day, although there are some centers that will go to 40 twice a day. The adults would be 20 milligrams twice daily or 40 milligrams daily. And once again, there are some centers that will use 40 milligrams twice a day still. So this is a little higher typically than what you would put a child or an adult on right away for, you know, some reflux disease, in which you're typically going to start on equivalent of omeprazole 20 once a day for an adult, for example. You definitely want to use it higher, and most places would still recommend at least a good 6 to 8 weeks of therapy before you decide, you know, what the treatment response is. Now, getting back to why we no longer require PPI as a requirement for the diagnosis, is there are no good predictive factors for who responds to PPI. So you would think if patient had reflux as a cause of their eosinophilia, and they put them on a high dose PPI and the eosinophilia goes away, that's why we would say that rules out reflux, and you need to rule that out before you diagnose them with EOE. What's been learned is that it doesn't really predict response. If you have, for example, an abnormal pH study, you're not more likely necessarily to respond to a PPI in your eosinophilia as if you have a positive pH study. And so nothing actually predicts whether that patient will respond to PPI. In these large studies, the response rate typically is between 30 and 60%, and that's between adult and pediatric patients, and it's similar whether you have active reflux based on a pH monitoring study or don't. And so because there's no predictive factors, and if you have reflux, you're more likely to respond or anything like that, we no longer requirement, and we say it's appropriate for any patient who has esophageal eosinophilia. Now, one question that comes up in my clinic all the time, especially in kids from parents, is they want to know the long-term risks of PPI. And what I'll say is we definitely don't have any data on what is the real adverse effect of PPIs when used for patients with EOE, because the idea is that if you're an otherwise healthy person and I put you on 20 years of a PPI, that's going to look very different than if I look at people who took PPI in combination with a lot of other issues, such as if they were in the ICU or had kidney disease or something like that. So in younger patients especially, I tell the parents, I personally am not worried, but we don't really have great data on taking otherwise healthy patients and putting them on a PPI for, let's say, 10 or 20 years. But I don't want to, downplay their concerns with adverse effects. So if that is a concern, that's where we use the shared decision-making on whether to use it or not. Now, swallowed topical steroids actually have the strongest amount of evidence in agreement with both societies, and both societies recommend topical glucocorticoids for treatment for EOE with moderate evidence and strong recommendation. The strong recommendation comes from very well-designed trials and response rate above PPIs. Most response rate in the studies is about 60 to 80%. Now, the most commonly studied swallowed topical steroids are budesonide and fluticasone, although there are studies with others for sure. The budesonide, as you probably are well aware, is in the form of a liquid budesonide that we normally would use in asthmatics. We would put it in the nebulizer and nebulize it and have the patient inhale it for asthma. But obviously, in this regard, we're having them swallow it for EOE. And so we take 1 to 2 milligrams a day for children, or 2 to 4 milligrams per day, typically for adults. We have them take that liquid vial, mix it with something to make it thick, have them swallow it, and no food or drink for 30 minutes. The initial studies making the viscous budesonide obviously used Splenda, 5 packets of Splenda per 1 vial, making it into a slurry. But studies have shown you can really use anything. And one of my patients today mixed it with applesauce and had very good response. So I see patients mix it with applesauce, pudding, thickener, whatever. You just want to make sure it's viscous. For fluticasone, we're using the asthma inhaler, which comes in a 44, 110, and 220 microgram doses. We use that same asthma inhaler, have the patients puff it into their mouth and swallow. So we put the puffer into the mouth, tilt it up to the roof of the mouth, puff it. You might see a little smoke come out the side. That's normal. Do it again. No food or drink for 30 minutes. Dosing is anywhere from the 44 microgram canister, 2 puffs twice a day swallowed, all the way up to some studies use the 224 puffs twice a day, although that's probably a little excessive. Most people will use either the 44, 110, or 220, 2 puffs swallowed twice a day, depending on the age or severity of the disease. And there is now one FDA-approved formulation of a swallow topical steroid. So it's a 2 milligram dose of budesonide in a 10 ml single dose pack that's already viscous, so the patient doesn't have to mix it up with anything. It's much easier. I will have to say, though, the recommended dosage for that 2 milligrams is twice daily, but in the package insert, it does state for 12 weeks in adult and pediatric patients age 11 years and older. Now, there's no reason to think it wouldn't be safe and efficacious for longer term use. But the package insert, based on the studies and the FDA, said that it's for 12 weeks of treatment. And so it's great, though, to have an FDA-approved swallow topical steroid for EOE, because we didn't have one for years. Okay, how about dietary therapy? So dietary therapy, what you'll see here is the quality of evidence is low. Our document suggests using an empiric 6-food elimination diet over no treatment, because that had the best amount of data at the time. Whereas the ACG just said we suggest an empiric food elimination diet as a treatment, and both have low quality of evidence with a conditional recommendation. Now, because the ACG came out later, you'll notice that it says providers may consider starting with a less restrictive empiric elimination, such as a 1 food or 2 food as the initial diet therapy choice, where the AGA JTF document said 6 food. We now have more data to show that you can just remove 1 food and almost achieve similar or better responses in some cases. So this is just one study that was recently published out of a consortium of clinics in the United States, in which they randomized pediatric and adolescent patients to either receive milk elimination, so complete dairy elimination, or dairy plus egg plus wheat plus soy. So a 1 food versus a 4 food elimination diet. Follow them for 3 months and then look at biopsy scores, histology scores, and symptom scores. And on what you can see on this is the 4 food is in the light blue per my eyes, and the 1 food is in a purple or lavender. And so on the left is symptom report breaking down parent versus child. And there's no difference in the child symptom report whether they removed 1 or 4 foods. The parent was a little bit better if you remove 4 foods, they thought, or at least in this study. But the histologic remission, so patients who had achieved less than 15 EOs per high power field, was absolutely no different. You look at the proximal and distal eosinophil counts as a change from baseline, and they weren't different, although actually the milk elimination was slightly better, not statistically significant, but definitely not worse, if anything better than the 4 food. And then the psychosocial changes, what you can see is the parent report may be a little better with the 4 food, but the actual patient, the kid, liked the dairy a little bit better, although not statistically significant. So in our clinic, based on this data and some others that have come out over the past 5 years, we essentially kind of leave it up to the patient and family to say, if you want to do a diet, could you do dairy and other foods? Do you want to just do dairy? If we're doing a one food, we really do recommend dairy, though, because there's not as good a data if you just remove something like egg or wheat. So if you're doing one food, just dairy. Although I tell you, in the pediatric patient population I talk to, once I start saying, this is actually what you're going to have to avoid. Oh, you like that mac and cheese? Oh, you like that pizza? Oh, you can't put cheese on your burger anymore. Oh, cooking with butter, it may not be the best way to do it if you're on a dairy. When you start going through all these, it comes a little bit harder, but it's having that discussion to say what might work for you and your family. And if this is something you want to do rather than use a medicine, let's try it. So a couple other things. Most data would suggest that milk is the most likely trigger, like we talked about. And in most studies, egg and wheat are probably 2 and 3 as the next most common triggers for EOE. When I started, there were a lot of people on elemental diets, meaning they literally swallowed a formula that was allergen-free, and it worked for almost every patient. I haven't put someone on a formula in over 10 years. I find that the quality of life for these patients is just a lot worse. And so we typically don't do that anymore. It's still an appropriate therapy for, more severe or a patient that wanted to do it. But we're trying to take quality of life into more account, realizing that if we could have good success with less foods, let's do it. And then lastly, as the ACG guideline pointed out, what we always tell our patients is symptoms should not be used to say which food causes EOE. So for example, you could have lactose intolerance and that's bad GI pain every time you eat dairy, but that doesn't mean it's your trigger for EOE because there are other things that can cause symptoms when you eat. Or the piece of steak that gets stuck is not necessarily going to get stuck because it's the cause of EOE. It may just be the texture of it, right? So you can't use what food the parent or patient thinks is bothering them as the cause for the EOE. All right, how about testing for the diet? In our document back in 2020, it suggested using an allergy testing-based elimination diet over no treatment, but it did say that was very low quality of evidence with a conditional recommendation. The ACG actually took the opposite stance. It said, we do not suggest currently available allergy testing to direct food elimination diets, once again, using the same very low quality of evidence. Now, if you read our document, it does say in there, due to the potential limited accuracy of currently available allergy-based testing for the identification of specific food triggers, patients may prefer alternative medical or dietary therapies to an exclusive testing-based elimination diet. So we were kind of saying, it's probably, you don't have to do this. And even more and more each year, you're finding less and less allergists doing testing. And I will tell you, anyone who gets referred to my clinic, I don't do any form of allergy testing to direct a diet. The one time I will do testing is to say, if you remove a food, especially if you're younger and you're sensitized, for example, you have a positive skin test, is there a concern that if I take it out for 2 years for EOE and I try to add it back in, we will see more symptoms consistent with an immediate food allergy like hives, swelling, trouble breathing. So in that case, maybe I would do testing to know if I take it out, should I be concerned putting it back in? But I don't use any kind of testing to say, oh, this peanut came up positive and you're eating a lot of peanut butter, maybe we should take that out. I've kind of stopped doing that in my own practice. All right. The last therapeutic option that we're going to go over for a few minutes is the biologics. As you're likely aware, we now have one approved biologic with an FDA indication for the treatment of EOE. In our document, because it came out before the approval of that, we said in patients with EOE, the AGA-JTF recommends using anti-IL-13 or anti-IL-4 receptor alpha therapy as therapy for EOE in a context of a clinical trial. So that medicine is dupilumab. So we said use that only in a clinical trial because it wasn't approved yet and we didn't have enough data. We said that's a knowledge gap. Now, since then it got approved, and so the ACG document was able to incorporate that, suggesting use of dupilumab to treat EOE in individuals 12 years of age and older who are non-responsive to PPI with a moderate quality of evidence, so that's good, and a conditional recommendation, and suggesting use of it as a treatment for EOE in pediatric patients 1 to 11-year-olds who are non-responsive with a low quality of evidence. Now, you'll notice that those two say non-responsive to PPI. That's based on the trials that enrolled patients in dupilumab studies had to have had a trial of PPI. So we don't have like a huge number of patients who got diagnosed right away, never were put on a PPI and started dupilumab. There's no reason it couldn't work, but you'll notice the wording is because that's how the trials were run. Now, in order, as the JTF and the AGA saw the approval, we had a meeting and decided not to change an entire guideline at that time just for one approval of a medication. What the American College of Allergy and Asthma and Immunology did instead was create a yardstick, which we got essentially authors on the guideline to give expert opinion on how to use dupilumab for eosinophilic esophagitis. So this was published in 2023, so it's a little more updated than the guideline. You can go pull it up if you want and kind of see expert opinion on how to incorporate dupilumab, such as, when would you biopsy afterwards? It answers questions like that. But it also says who would be a good candidate for dupilumab. And then, unlike the ACG guideline that says you have to be PPI non-responsive, the yardstick gives scenarios where it might be first line. A patient gets diagnosed with EOE, and for example, they already have moderate, persistent, difficult to control asthma and or atopic dermatitis and or nasal polyps. Maybe that makes a lot more sense to put that patient on dupilumab, treat 2 or 3 conditions at once, and in that setting could even be cost effective because one of the downsides of dupilumab is the cost. And then it gives other scenarios like reasonably when could you consider it a step up therapy. The other thing about yardstick here says is if a patient has a strong preference to avoid diet or swallow topical steroids or PPI, there's no theoretical reason why it could be used as first line. So the yardstick gives you a little bit more leeway as a provider, as a prescriber, to say maybe this is a good patient to use it even as first line. This is the package insert monograph for dosing of dupilumab. So right now it's approved down to 1 year of age for EOE. They have to weigh at least 15 kilos. If they're 15 to 30 kilos, it's 200 milligrams sub-Q every other week. If they're 30 to 40 kilos, it's 300 milligrams every other week, which is nice in the pediatric population because every other week is definitely better than weekly shots. But if they're 40 kilos or more, it's 300 milligrams every week. And you'll notice that is a slightly different dosing than how it's used, for example, in asthma or atopic dermatitis. So just to kind of finish up here, one thing to make sure you understand patients and families understand once you put them on therapy is that EOE is a chronic disease. None of these treatments are a cure. All right, so this quote is straight from the ACG guidelines. Say we advise providers to counsel patients that because it's a chronic disease, EOE is chronic disease activity almost universally recurs when treatment is stopped. I have had 1 or 2 patients who stopped taking their medicines, followed up 2 years later, and biopsied and were normal. That is not the norm. It's almost unheard of. So I always tell patients and families, as far as we know, this is going to be chronic and for your lifetime. Just because you start a treatment doesn't mean you have to do the treatment for a lifetime. We can change up the treatments however you want to do it. But, we're going into this thinking that whatever we do is going to be, for a lifetime. Now, if you find the food that causes it, you remove the food and they live that life without eating the food, that's fine as well. Obviously, as we've talked about, therapy should be tailored to achieve the patient's goals. And ideally, medication should be weaned to the lowest effective dose. Now, this is really most specific for the PPI, the swallowed topical steroid. What we will do in our clinic is, let's say they're on a swallowed topical steroid and they're controlled and they're on fluticasone 220, 2 puffs twice a day. We will then wean it to 110 like we would do for asthma, follow them. They may or may not need a biopsy if they're doing well eventually, and then try to even wean them to the 44 micrograms 2 puffs twice a day. So weaning them as tolerated based on symptoms as well as biopsy. So clinical monitoring, obviously monitoring the symptoms, and you can incorporate that IC app into it. That'll include both symptoms and histology scores to follow them over time. We don't use 15 as like whether or not we're successful. So we have a patient that goes from 80 EOs and they're down to 20. and they have no symptoms, we discuss with them that it's not perfect, it's not completely normal. That may over time lead to some scarring, but if you're doing well, we can monitor you. We don't have to reach the magic number of less than 15 before we say it's a treatment success. But we do want to see some improvement in eosinophil count. If we are going from 80 eosinophils to 80 eosinophils and the patient feels better, we have a discussion with that patient and say, look, I know you feel better, but there's still a lot of inflammation. And the downside of that inflammation is, as best we know, it will lead to scarring down the road and more likely have symptoms down the road. We would recommend treating that inflammation even though you feel better. And we have that discussion with the patient. So following treatment response is not just symptoms, it's symptoms and histology, and then having the shared decision-making with the family and patient. I'm going to close by showing the ACG guideline highlights. This is a free, quick PDF that you can click on that link or follow that link or just Google it. And then what it shows is most of what I talked about in one little PDF that you can look at or put in your clinic. It gives you the dosing, the recommended dosing for budesonide and fluticasone. It gives you the dosing of the dupilumab as well as the PPIs. It talks about the diet, talks about everything we talked about here. So a nice little one-liner that I like from that ACG guideline that you can go back to just for a quick refresher. So in summary, they put this together. I liked it. It's the 1, 2, 3. 1, it's a chronic relapsing condition. Management requires a multifaceted approach with treatment options. And most importantly, in that multifaceted is taking the patient and family or parent into account when deciding, and gets us to number 3, using shared decision-making to find the optimal therapy for each patient. And with that, I will stop right at a quarter till and hopefully go through some questions.
Yes, yes, we have some questions. Thank you for that presentation. And what I really like, my background is as a respiratory therapist, also an asthma coach here, in addition to my education role. But we talk a lot about shared decision making with our asthma coaching participants, but also, when we talk about you're feeling good, you're on a steroid, don't stop, continue. So whenever you mentioned that clinical monitoring, just continue that, even if you're seeing some improvement. So I personally love that it all aligns because we're saying the same message to our patients and asthma coaching participants. So thank you for that. So I will start with our first question. It says, what has been your joint clinical experience with patients who are identified on the spectrum and have components of food texture, color aversion, refusal, or a tendency towards spitting, vomiting, or rumination?
So that's a great question. So I was laughing because we have a current allergy fellow who does our EOE clinics, and they are convinced that EOE is not a real disease. It's just they have a lot of other things because so many of our patients have something like this that you're talking about or have something else. So we do have a ton of patients who may be on the spectrum or have speech therapy for issues of texture aversion, everything. Let me tell you, it is really, really hard. So we unfortunately, we don't have a speech therapist in our clinic. We used to have a nutritionist, which was nice. They don't come anymore. We refer them to speech therapy, obviously, to work through it. And then we will message back and forth with the speech therapist saying, these foods are okay to try, these are not. What we try to do best from our standpoint is treat the disease part of it as best we can. And what I mean by that is, if there's inflammation there, how do I know that's not causing their food aversion? And that's what's hard. So if I can clear their eosinophilia, if I can clear their inflammation, I tell the speech therapist that I don't think the EOE is any longer playing any role in their food aversion or in their texture issues. And the rest of that is up to the speech therapist. If they have active inflammation, then how do you know the swallowing isn't really bothering them too? So I do everything I can in those patients to clear the histology and then let them work with the texture food aversion issues. But it's very hard. It's a great question.
Thank you. We have a couple of questions, so I'll try to combine the best I can related to allergies. So How do you coordinate care with patients that have multiple allergic comorbidities? And a couple of people are asking about asthma, atopic derm, and how pollen and mold allergies exacerbate EOE.
Oh, it's a good question. I'm a board certified allergist, and I run the clinic with a board certified gastroenterologist. So we are lucky in that we combine, talk to each other, we make a treatment plan together. Now, if that patient has atopic dermatitis, asthma, allergic rhinitis, I manage that during our patient visit along with the EOE. Just as if they have constipation or functional bowel disease, that gastroenterologist manages that at the same time, because all of these play a role in that patient. So if they have constipation, it's probably causing abdominal pain. So is it the EOE or the constipation? If they have rip-roaring allergic disease and it's draining and they're having swallowing from that, that's making it confusing as to what the symptoms are. And so it is important to treat those comorbidities by an allergist and a gastroenterologist, if you're lucky to do it at the same time, but if not, make sure they're seeing both to manage those comorbidities. As far as aeroallergen and its role in EOE, there are lots of reports that there's probably some role being played there. Some of that's based on seasonality of diagnosis. There's a few studies which looked at a few patients and they got their EOE under control. They didn't change any management for the EOE, and they scoped them throughout the year. And they did show an increase in eosinophilia during pollen season, for example, tree pollen season in the spring, if they had tree pollen sensitization. Now, that was only a very few patients. So we think that maybe in a minority of patients, aeroallergen, meaning you're breathing it in and it's getting to the food pipe in addition to the nose and airways, can exacerbate or cause some eosinophilia in a patient with EOE. But we think for the majority of patients, that's not the case. So for example, I don't ever put a patient on EOE on allergy shots because I think it's going to help their EOE. But if it does help their rhinitis, maybe that helps in some symptoms, and maybe you get some benefit to the EOE. But it's definitely not the main cause, and it's not something I would target beyond just saying target the comorbidity and it'll help out with symptoms.
Okay, awesome. And there's kind of like a follow-up question to that as well, regarding testing for environmentals such as pollen, mold, and animals, and if it would typically show on that biopsy.
Yeah, not on the biopsy once again, as best we know, for at least the majority of patients, but managing the comorbidities. So in our clinic, if the patient also has symptoms of rhinitis, symptoms of asthma, for example, most of those patients are going to get aeroallergen testing, even if that wasn't their primary complaint. They ended up at our clinic and, oh, you know what, you have a lot more rhinitis than you're letting on. I'm going to test you, look to see how allergic you are, treat those allergies as a treatment of a comorbidity to help out with symptoms, but not necessarily because I think it's going to do much for the EOE itself.
Okay. Shifting gears to pediatrics, are there any red flags for EOE that a primary care pediatrician or allergist should be aware of, specifically more so to the PCP?
Yeah, and the younger kids' failure to thrive, I mean, they're going to get referred to GI anyway, and usually if it's bad enough, get scoped, and that's how they come to our EOE clinic, for example. It's fascinating. I don't have any red flags that will predict that the worst possible outcome in EOE, for most patients is the acute food impaction where they won't choke in the sense of they can breathe, although they feel like they're choking. And it's very, very uncomfortable. They'll end up in the emergency room. And there's nothing to predict that, unfortunately. So there's no red flag in that sense, but symptoms of, food getting hung up is something that, oh, maybe you need to be evaluated if that steak is always getting hung up and you're having trouble swallowing it. That would be the best I could say, but unfortunately, there's no red flag that'll say this is the kid that's going to end up in the emergency room.
Okay, and our last question, what are your thoughts on esophageal dilation for both pediatrics and adults?
Yeah, I mean, esophageal dilation definitely makes patients better. And it's funny, if you ask new diagnosis EOE patients, oh, does anyone in the family have this? No. Well, does anyone in the family have trouble swallowing or get their food pipe stretched? You're like, oh, yeah, Aunt so-and-so gets her food pipe stretched every few years to help her swallow. Like, oh, yeah, that patient has EOE. Um, the dilations make patients feel better, but they don't treat the underlying disease, right? You're not getting rid of the fibrosis. You're not getting rid of the inflammation. So it will come back. If that's what a patient chooses to do, so be it. That's how they can treat it. In the pediatric world, we tell families like, some of our patients get dilated and we say, there's a lot of inflammation there we didn't treat. If you don't want this to happen again for your long term, we would recommend treating the inflammation. So I don't have any problem with dilation. It's kind of a Band-Aid. It's not treating the underlying cause. So ideally, you want to treat that in addition to the dilation or after the dilation.
Thank you. Well, thank you so much again, Dr. Lieberman, for it's been a great presentation and for answering so many of our questions. For all those in attendance, Zoom will be emailing you in a few days with a link to this recording, an evaluation, and also supplemental resources. Again, we're thrilled to share that we have 2 upcoming webinars. The next one on June 4th at 4 p.m. Eastern Time. We invite you to join us for our Black People Like Me virtual conference series. It's going to be session 6, a closer look at food allergies in the Black community. In this special session, we have a moderator and patient advocate, Sharina Gibson, who will share her lived experiences and personal journey with food allergies. So join us as she talks about her journey and triggers as we present that in different skin tones. Then on June 12th at 4 p.m. Eastern, join us for another engaging and informative advances webinar. Our title is Anaphylaxis, Changing the Treatment Landscape. Dr. Teresa Bingman will discuss current guidelines, emerging therapies, evidence-based approaches to improving patient outcomes, which offers practical insights on the acute treatment and prevention of anaphylaxis and the involvement in the treatment landscape. Thank you once again from all of us at the Allergy and Asthma Network, where we strive daily to be your trusted resources for people with allergy, asthma, and related conditions. Thanks again, Dr. Lieberman.
Thank you.
Bye-bye. Have a good afternoon, everyone.